there's an aspect to this which I think does come into the palliative region, which is about how you can expedite the whole process for patients so that frustration, anxiety, concern and uncertainty are eliminated if patients feel that they're on a high quality, well signposted, efficient pathway. I want to convey to people who don't live and breathe this in secondary care what it actually means in a hospital like this to have to deal with the tsunami of fast-track referrals, and then hope to take it a bit further forward by indicating to you, from what I've seen, what's going on the ground at a national level and a regional level, so that ultimately we can come up with an understanding of what's going on and then perhaps look at approaches that we could work on together to make it more efficient and more successful at a local level. I've sort of given you this tale of woe about the frustrations that I and other colleagues have with the current fast-track system, but we must be doing something right. This graph shows the outcomes for cancer in this area back to about 1995, which was when the first cancer plan was initiated. So this was when we first of all started to get super site specialisation with proper teams for breast cancer, bowel cancer, lung cancer. It's where we started having our multidisciplinary meetings where each individual case was analysed. This is where we started having the whole fast-track process of getting people into the system quicker. And it is clear that the outcomes for patients in this region are better than they were. That goes without saying. And indeed, the green line there, which is the region we're in at the moment in northwest Dorset, has done better than almost anywhere in the country. So these systematic top-down approaches, raising standards across the board, certainly make a difference. Really, I think what I'm hoping for is that we'll see a step change of even greater benefit if we just get ourselves organised and pull together all the various initiatives that are underway. Having seen the shortcomings in the fast-track service, what I'm really keen to see is an advice and guidance service from secondary care developed. So, for instance, a patient comes to the GP practice, presents with a pretty worrying symptom, and a fast-track referral form is submitted. Actually, there's every possibility that nothing is going to happen for 13 and a half days before that patient turns up in outpatients. To me, that's a critical and criminal waste of time, and it's a sad situation for the patients just sitting there waiting for things to happen. My guesstimate, based on the number of fast-track referrals nationally in this country and the number of GPs there are in this country, is that each GP makes about 30 fast-track referrals a year. Now, some of those are going to be barn door obvious. They've just got to go straight to colorectal or straight to the lung team. But there'll be a number of those, not a large number, in whom the situation is much more nuanced. And the fact that at the moment there's no formal system for getting advice and guidance from secondary care about what to do with those patients means that people are just put into this sausage machine of the fast-track process. So one proposal is for there to be an advice and guidance service in secondary care based around oncology when it's clear that patients have got cancer, but I think that there's also a need for an advice and guidance service of a generic kind based on gastroenterology and other disease sites, so that the process can be more professional, more sort of integrated. I mentioned that there is a gap between the fast-track referral going in and anything actually happening. And this archaic system where you have to wait until you sit in front of some human being in a horrible overcrowded outpatient clinic is, so last century. Dorset County Hospital is very fortunate in having for many years initiated and then disseminated a novel system for dealing with suspected colorectal cancer. So all the patients who are on a fast-track process for suspected colorectal cancer, rectal bleeding or other bowel symptoms, what happens is that instead of waiting to see some stuffed shirt of a consultant colorectal surgeon in outpatients, you've got an intelligent, sort of devoted specialist nurse who sets up an appointment with that patient very, very quickly to start the process of assessing their problems, investigating them and working out what steps need to be taken by telephone within a couple of days. The aspiration is for this to be more broadly rolled out across Dorset for colorectal cancer. It's taken quite a long time. Certainly the person who initiated it at this hospital now works in London, is rolling it out there. So this whole process of trying to start the ball rolling in a more intelligent, interactive way earlier in the process makes a lot of sense. For a long time I was interested in the idea of unknown primary cancer because it's a strange but significant numerically clinical entity for which treatment options seem to be very limited, and this group of patients didn't get treated very well. And the aspiration through NICE was to try and improve the way they were treated, but it became very clear very quickly that the problem for patients with metastatic malignancy without an obvious primary source wasn't really the treatment side of things, because basically they just got metastatic cancer, they're going to do badly. The problem for them was the system, which meant they just sort of swung around the plug hole for a long time before actually dropping into the right place, if they ever did. So what we've got in place now for patients who are referred with metastatic malignancy without an obvious primary site is a very slick, lithe system which works, 5 days a week, not just one meeting a week, but where a team of people identify the patient, decide what needs to be done, get things expedited, get the results through in real time, make the next decision rather than waiting for the next week or for the next clinic, keeping in touch with the patient through the CNS, who's their sort of link person, bringing to bear the things that they need during that journey, which is often palliative care, symptom relief, information. And so this model we've now got in place for the metastatic malignancy patients is really very similar to what's proposed with this multidisciplinary diagnostic centre. So we've already got a model that's working, and so that's a jumping off point for broadening it to a wider group of patients. I think that for us to care for our patients in the best possible way means that the systems we've got in place are not as good as they should be, and that's really the reason for us being here, to try and analyse this and see what we can do better. But what there is urgently now is a need, I think, for a local Dorset organisation which is able to take this foot forward, looking at the various initiatives I've talked about and seeing how they can be brought to bear locally. And it may well be that you are the people who are going to achieve that.
I think the main thing from today has been listening to I think the message from secondary care about fast track referrals in terms of the impact that early diagnosis has on secondary care, the volume of workload and the cost that they get refunded for the fast track service in terms of resources, and the difference in looking at it from primary care and secondary care and the need to talk to each other, because as a GP I hadn't realised about the degree of targets and the sanctions that secondary care get, or the amount of funding that they get for the fast track service. And I think having that understanding and communication between primary and secondary care is going to help us form a better service. So I think it was really about the need to work together and the fact that these proposals are supposed to help that, but I think again communication between us as GPs and secondary care is key to that.
I thought it was very interesting to hear about all the work that's been done in the various organisations to try and improve things across the board. Everyone is working towards the same goal, different people in different ways, but we've all got the same ambition. I think the multidisciplinary diagnosis centres sound like a good idea. It's an excellent idea to get someone in, put them in the whirlpool, get the whole thing sorted out there, and then none of this lag and waiting, and then being perhaps passed back to primary care with no firm diagnosis, with still symptomatology. So I think it could be an excellent way forward.
I think the thing that struck me the most was the complete agreement between primary and secondary care professionals that something needs to change, that the system needs to improve, not just for our patients but perhaps for ourselves and our families. And the most unanimous factor was almost that we need to go back to the way it was. We need to go back to primary and secondary care communicating directly as they used to do, although we're short of time, that should still be a priority, and that we need to be taking a more holistic, generalist approach to assessing these patients so that they're not just given a diagnosis that's eliminated, but a diagnosis for the symptoms that they've got, and that multidisciplinary, holistic approach is the way forward. And I think we had fairly unanimous agreement on that across the board.
Well, the first thing I'd like is for people to carry on doing the excellent job they're doing, because it's quite clear that the excellent outcomes we see for cancer in Dorset are a part of everybody's contribution, particularly primary care. The second thing I'd like people to do is not be demoralised by the shortcomings which I highlighted, because I think there's opportunity for improvement. I would really like people to feel that they've got some ownership of the initiatives that are coming out nationally and regionally, so that we can put together a working party which will achieve real change in Dorset, analysing the pathways we have at the moment, perhaps stripping them down and starting again, but building something which is better, which I'm sure is achievable.